Sites and subsites of head. The majority of tumors arising in the head and neck, other than non-melanoma skin cancers, arise from the squamous mucosa that lines the upper aerodigestive tract (UADT) and are predominantly squamous cell carcinomas. The UADT begins where the skin meets the mucosa at the nasal vestibule and the vermilion borders of the lips, and continues to the junction of the cricoid cartilage and the cervical trachea and at the level of the cricoid where the hypopharynx meets the cervical esophagus. The UADT is organized into several major sites that are subdivided to several anatomic subsites. The major sites include 1. The oral cavity, 2. The oropharynx, 3. The hypopharynx, 4. The larynx, 5. The nasopharynx, and 6. The nose and paranasal sinuses. Oral cavity. The oral cavity is a common site for squamous cell cancers of the UADT. Probably because it is the first entry point for many carcinogens. The anterior aspect of the oral cavity is the contact point of the skin, with the vermilion of the lips extending posteriorly to the junction of the hard and soft palates, and with the anterior tonsillar pillars and the circumvallate papillae forming the posterior limits. The major subsites of the oral cavity are the lips, anterior tongue, floor of mouth, buccal mucosa, upper and lower alveolar ridges, hard palate, and retromolar trigone. The trigone consists of the mucosa overlying the anterior aspect of the ascending ramus of the mandible. Tumors of the oral cavity tend to spread regionally to lymph nodes of the submandibular region, level 1, and to the upper and middle jugular chain lymph nodes. Levels 2 and 3. Because of accessibility and the risk of involvement of bony structures, treatment with primary radiotherapy can lead to radionecrosis of the mandible or maxilla. Moreover, oral cavity squamous cell carcinomas may be less sensitive to chemotherapy and radiation, relative to oropharyngeal or laryngeal cancers. Thus, primary treatment for most tumors is surgical. Advanced stage disease may receive adjuvant radiation therapy. Positive surgical margins, multiple involved lymph nodes, and/or extracapsular tumor extension call for consideration of postoperative chemoradiotherapy to improve local disease control. Oropharynx. This region begins where the oral cavity ends at the junction of the hard and soft palates superiorly and the circumvallate papillae inferiorly, and extends from the level of the soft palate superiorly, which separates it from the nasopharynx, and to the level of the hyoid bone inferiorly. The subsites of the oropharynx are the tonsil, base of tongue, soft palate, and pharyngeal walls. Cancers of the oropharynx often metastasize to upper and middle jugular chain lymph nodes, levels 2 and 3, but can also spread to retropharyngeal lymph nodes, which distinguishes them from oral cavity tumors and must be considered when treating oropharyngeal cancers. Tumors in the oropharynx have traditionally been treated with radiotherapy, as a single modality for T1/2 or N0/1 staging. For patients with more advanced disease, T3/4 or N2B/C3 staging, chemoradiotherapy, most often with a concomitant approach, has become standard. Cisplatin, administered during weeks 1, 4, and 7, has most often been studied and may be considered a standard. There has been a near-epidemic rise in the incidence of oropharyngeal cancer related to human papillomavirus (HPV) infection, most often occurring in younger patients lacking the traditional risk factors of significant tobacco and alcohol use. HPV-related tumors demonstrate a significantly higher cure rate. Recent advances in surgical techniques, including transoral laser microsurgery and transoral robotic surgery, have allowed for surgery to be considered as an integral part of combined modality treatment. Hypopharynx. The hypopharynx has its superior limit at the level of the hyoid bone, where it is contiguous with the oropharynx, and it extends inferiorly to the cricopharyngeus muscle, as it transitions to the cervical esophagus. The major subsites of the hypopharynx are the piriform sinuses, the postcricoid region, and the pharyngeal wall. Tumors often present here at advanced stages and can be difficult to cure, and because of their location can impact swallowing and speech function adversely. Spread to the upper, middle, and lower jugular lymph nodes, levels 2 IV, and the retropharyngeal nodes is common in these cancers. Two other hallmarks of hypopharyngeal cancers are submucosal spread and skip areas of spread. Surgery had been the mainstay of primary treatment for hypopharyngeal cancers for many years, but increasingly, radiotherapy and chemoradiotherapy are used to treat cancers in this location with success. Larynx. The larynx is the most complex of the mucosal-lined structures of the UADT. The important roles of the larynx in speech, swallowing, and airway protection make the treatment considerations of cancers of this structure varied and controversial. The larynx is bordered by the oropharynx superiorly, the trachea inferiorly, and the hypopharynx laterally and posteriorly. The larynx is comprised of a cartilaginous framework, and is subdivided vertically by the vocal folds into the supraglottic, glottic, and subglottic subsites. The supraglottic larynx includes the epiglottis, which has both lingual and laryngeal surfaces, the false vocal cords, the arytenoids cartilages, and the aryepiglottic folds. Anterior to the supraglottis is the pre-epiglottic space. This is a complex space with a rich lymphatic network that contributes to the early and bilateral spread of tumors that arise from supraglottic structures to upper, middle, and lower jugular chain lymph nodes, levels 2-4. The glottic larynx describes the true vocal folds, where they come together anteriorly at the anterior commissure, as well as where they meet the mobile laryngeal cartilages at the posterior commissure. The glottic larynx extends from the ventricle to 1 cm below the level of the true folds. The vocal folds are lined with stratified squamous epithelium, which contrasts with the pseudostratified, ciliated respiratory mucosa lining the remainder of the larynx. Glottic laryngeal cancers tend to metastasize unilaterally, and regional spread is less common than with supraglottic tumors. Between the thyroid cartilage and the vocal fold lies the paraglottic space, which is continuous with the pre-epiglottic space. This serves as a pathway for submucosal spread of tumors from the glottis to the supraglottis and/or subglottis, or vice versa, which is known as transglottic spread. The subglottic larynx starts 1 cm below the vocal folds and continues to the inferior aspect of the cricoid cartilage. While it is rare for tumors to arise initially in the subglottis, tumors arising in the supraglottic or glottic larynx commonly spread in a transglottic fashion to involve the subglottic larynx. Subglottic tumors tend to metastasize to paratracheal, level 4, as well as middle or lower jugular lymph, levels 3 and 4, node groups. Treatment of laryngeal cancers varies widely from center to center. For early-stage lesions, radiotherapy and transoral endoscopic excision are the most common treatment options. Both yield excellent tumor control, but proponents of each modality often disagree on the functional sequelae of the two types of treatment. However, good long-term functional data are lacking. Treatment of more advanced tumors can be even more controversial, but while total laryngectomy was long held as the gold standard for treating T3 and T4 larynx cancers, chemoradiotherapy has been shown to be quite effective in achieving local regional control, survival, and organ preservation. Concomitant chemoradiotherapy may be most appropriate for T3 and early T4 primary lesions, while upfront surgery with adjuvant postoperative treatment can have improved disease control for advanced T4 tumors. Treatment of both sides of the neck must be taken into consideration when treating supra- and subglottic tumors, and unilateral neck treatment is considered for patients with advanced glottic tumors. Nasopharynx. The nasopharynx is a cuboidal structure bounded anteriorly by the choanae at the back of the nose, where pseudostratified ciliated columnar cells are found. The roof and posterior walls of the nasopharynx are made up of the sphenoid bone and the upper cervical vertebrae, covered with a stratified squamous epithelial lining. Inferiorly, at the level of the soft palate, the nasopharynx meets the superior oropharynx. The opening of the eustachian tube is found at the posterior superior aspect of either lateral nasopharyngeal wall. Therefore, impingement of this opening by a nasopharyngeal tumor can lead to eustachian dysfunction manifested by a middle ear effusion and hearing loss. Thus, all adult patients with an unexplained unilateral middle ear effusion, particularly in areas where nasopharyngeal carcinoma is endemic, such as southern China, northern Africa, and Greenland, should have their nasopharynx examined. The adenoids, consisting of mucosa-covered lymphoid tissue, are found posteriorly and superiorly in the nasopharynx and are more prominent in children than adults. While minor salivary tumors can occur in the nasopharynx, most nasopharyngeal cancers are derived from the mucosal lining and fit into one of the 3 histologic subtypes described by the World Health Organization (WHO). WHO Type 1 nasopharyngeal carcinoma (NPC) is keratinizing squamous carcinoma, and WHO Type 2 is nonkeratinizing squamous cell carcinoma. WHO Type 3 is an indifferentiated tumor, also known as lymphopithelioma. The Epstein-Barr virus is thought to play a pathogenic role in the development of type 2 and 3 tumors. Nasopharyngeal carcinoma may also metastasize to retropharyngeal and parapharyngeal lymph nodes, as well as lymph nodes along the upper, lower, and middle jugular levels 2-5 chains and the posterior triangle of the neck. Level 5. Early stage NPC is most often treated with radiotherapy alone. And in more advanced cases, such as T3/4 and/or N+ patients, concomitant chemotherapy is being increasingly utilized. Surgery is rarely used in salvage situations at the primary site or neck. Nasal cavity and paranasal sinuses. The paranasal sinuses consist of the paired maxillary sinuses, the superior frontal sinuses, the bilateral ethmoid system, and the central sphenoids. This region includes the lining of the nasal cavity, medial maxillary walls, as well as the nasal septum. The majority of sinonasal carcinomas arise in the maxillary sinuses and are most commonly squamous cell carcinomas, although adenocarcinomas are described, especially in woodworkers. Because of inherent bone involvement, initial treatment is usually surgical, with consideration for adjuvant radiation therapy based upon stage and pathologic findings. Reconstruction and rehabilitation, especially in cases with orbital involvement, may be prosthetic or tissue-based. Sinonasal carcinomas of the anterior skull base include a variety of pathologies. Standard treatment is multidisciplinary, including craniofacial surgical intervention with adjuvant radiation with or without chemotherapy. Charged particle radiation, such as proton beam radiation, may be considered in patients with involvement near the anterior skull base and/or orbit. Due to the improved control of the beam's depth of penetration, treatment dose can be optimized, while minimizing collateral damage to adjacent vital structures.